the invitation. I'm going to talk about the pathogenesis of bone disease. There will be a little bit of basic lab research in there as well. A story of a very unusual patient with osteoporosis who also did have celiac disease, and I have some very recent results that we've just got hot off the press. They are unpublished. My collaborators in the audience haven't seen them either, so that is exciting in itself. I'm very grateful specifically to Coeliac UK for funding the development of a large cohort of patients with celiac disease in Edinburgh, in whom I hope we'll be able to answer some of the questions about screening for osteoporosis, pathogenesis of osteoporosis. By way of background then, osteoporosis itself, a disease of reduced bone mass and architectural weakness leading to increased fragility and fracture risk. And ultimately it's all about fractures. To digress from the main subject of the talk, in young women the commonest fractures are wrist fractures. Women have the good common sense to put their arms out if they're going to fall. In older women, it becomes hips and spinal fractures that predominate. You can be uncharitable and say that men who never show an excess of wrist fractures simply lack that common sense approach. And maybe they develop their osteoporosis later. What the picture on the left shows you is the natural history of osteoporosis over time. So during adolescence, your bone mass rises to a peak in the 20s and 30s. And then from 40, we all tip off a cliff of bone mineral density decline, which is sharper in women than in men. And so age and sex remain the key determinants. Bone density or osteoporosis being defined as a bone density less than 2.5 standard deviations. You can now see the osteoporotic patients here sitting at 2.5 standard deviations below the mean of normal controls. If you want to take out the effects of age, you can use a Z-score where you standardize against age-matched controls. And ultimately, osteoporosis develops as an imbalance between the normal formation of bone and the normal destruction of bone that goes on all the time. So you renew your skeleton many times over your lifetime, and osteoporosis is contributed to by celiac disease in a whole host of different ways. The key points are there in the middle. A failure to absorb vitamin D and calcium will lead to a failure to mineralize your osteoid, which is the light blue stuff on the right. A low body mass decreases the amount of weight bearing your bones do, which stimulates bone formation. Chronic inflammation is a stimulus to bone resorption, and of course secondary hyperparathyroidism. Osteoporosis is the commonest complication of osteoporosis. Estimates vary wildly, 1 in 4 patients, perhaps on average. And I think it's fair to say that there is no consensus about exactly who should be sent for bone density scanning and how frequently we should be scanning, despite the frequency of this as a complication. I should have said at the beginning bit when I said wrist fractures were the most common. In celiac patients, wrist fractures are the most common fracture as well, so they're clearly a common sense carrying bunch of patients. This is the bone remodeling cycle. So your bone normally sits in a quiescent state, but in response to trauma, osteoclast activity is stimulated, so you switch on resorption. However, the osteoclasts switch themselves off, stimulate osteoblast activity to replace the resorption pit, and you end up back where you started. And if that's exactly balanced, you end up with no net gain or loss. The on switch for osteoclast activity is a receptor called RANK, receptor activator of NF-kappa B, and that's the key mediator of osteoclast differentiation. The body has a natural inhibitor of RANK called osteoprotegerin, or protector of bone, and that's stimulated by bone marrow stromal cells and blocks the stimulation of RANK. And that's a key way that you regulate the switch between resorption and formation. Bear with me. We've described a novel syndrome where the patient developed an antibody against osteoprotegerin and took out this off switch, leaving the patient with a permanently switched on syndrome of bone turnover and bone resorption. And this potentially represents a novel tool for osteoporosis risk assessment, but needs to be validated in clinical cohorts, which is ultimately what we're hoping to do with the support of Coeliac UK. I'll take you through the index case. So he was a 40-year-old man who presented almost 10 years ago now when I was a trainee rheumatologist. He'd had a trial of strength with his young son, where his son had said, "I'm stronger than you, Daddy," and his daddy said, "No, you're not," and tried to pin his arms to his side, and his son had pushed him apart and had dislocated his daddy's shoulder and broken his collarbone for good measure. So he was sent into A&E. They recognised it was an unusual mechanism of injury, but they did do a host of different blood tests, and they referred him up to rheumatology for further investigation. We then ultimately, he did some serology. I'm very keen on doing celiac serology. And he did have occult celiac disease, though he was entirely asymptomatic of it. He had eventually a bone biopsy, which showed a mild mineralization defect. So clearly the immediate assumption was this was osteomalacia. He had celiac disease, he was vitamin D deficient, and that's why he was fracturing. Typically in osteomalacia, you have these thick seams of osteoid which are unmineralized. You don't have enough vitamin D, you don't get the calcium to mineralize your osteoid. The patient's bone biopsy had thin seams of osteoid only, and his bone biochemistry was just not consistent with osteomalacia. So he had low-ish levels of vitamin D, which is pretty normal in Scotland. He had suppressed PTH and he had elevated calcium, which is pretty much unheard of in osteomalacia. He had some kind of autoimmune diathesis going on, and he had his thyroid function checked in A&E, which was quite impressive. I'm not quite sure what they were thinking, but he did have hypothyroidism. Okay, this was his isotope bone scan, which is normally done if you're worried about malignancy, to try and pick up a single hot spot of bone where you have perhaps a metastatic deposit. Instead of a single hot spot, you see the whole skeleton lighting up. So this is a diffuse process that is going on throughout the entire spine. The entire skeleton. This is his bone biopsy, on which you would normally expect, if you're lucky, to see a single osteoclast. Everything marked in red is an osteoclast, so he has dozens of osteoclasts eroding away his skeleton. And there is a reactive seam of osteoblasts trying to repair, but it's outweighed by this intense osteoclast activity. Very unusual appearance of a bone biopsy. He had very severe osteoporosis. He had a T-score of minus 6.6, so minus 2.5 being the normal cutoff. This was pretty much at the limit of detection of the scanner. And he deteriorated despite appropriate treatment of his celiac disease. So he was given lots of vitamin D and calcium, and his thyroid was treated as well. And as you can see on his spine x-rays, he developed wedging compression fractures of multiple vertebral fractures. He lost about 6 centimeters in height over the course of his illness and was sitting in our ward with these progressive events and no explanation for what was going on. And certainly as a trainee rheumatologist, I had no idea whatsoever what was going on. We were all a little bit scared and a little bit anxious, it has to be said. A repeat bone mineral density scan had deteriorated despite appropriate management of his celiac disease, and repeat duodenal biopsies suggesting that he was very compliant with his diet. He had markers of bone turnover that were also elevated, and on the basis of the bone biopsy and the basis of an increased bone turnover, even though we hadn't got any idea of a diagnosis, we just went ahead and treated him with the most potent anti-resorptive therapy that we could lay our hands on, which was IV zoledronate at the time. And he staged a frankly miraculous recovery at that point. So he went from having bone density T-scores of minus 6.6 or minus 7, this is over 5 years of follow-up, to normal bone density. And at the hip, his bone density improved once again. And since this time, he's suffered no further fractures. And he cycles into clinic quite happily, considering himself a medical phenomenon. I was doing a PhD in gout genetics at the time he presented, or shortly afterwards I started doing that, and then I was persuaded that I should look into his case and see if we could work out what was going on, and then got completely derailed from gout genetics. Otherwise I wouldn't be here, clearly. So we came up with a couple of theories which proved dead ends, but this was the theory that we ran with in the end, that he developed this autoantibody response to this molecule called osteoproteterin. It had been reported in clinical trials of a recombinant OPG that was used as a treatment for osteoporosis, so there was a little bit of a steer that you could do it. We developed a test in the lab where we just bought osteoproteterin off the shelf, mixed it with serum from the patient. If he was recognizing it, you'd get an immune complex. You can pull immune complexes out of serum with beads coated with protein G. You just recognize the immunoglobulin component. And if you've got recognition of OPG and you put that down a Western blot, you can do, with this assay, you can then recognize by inference that there must have been an antibody that was recognizing it. And after a lot of trial and error, we got this positive band on a blot which suggested our patient did indeed have an antibody to OPG. So that was quite exciting. And we were also able to show that in a functional assay that his serum inhibited the effects of osteoprotection on cell signaling, so that it was not just recognition, but it was inhibition. So that was then written up as a case report, and I've been living out the consequences of that now to see whether this is something that was simply a one-off, and clearly a very unique case, but whether that could give us insights into mechanisms of osteoporosis more generally in other disease cohorts, or indeed in general populations. We got a very tentative steer that there might be something going on in celiac patients using the IP assay. We got kind of weakened, a little bit shaky bands seen in some patients with celiac disease. They possibly had non-significantly lower bone density scores, certainly not significant. And I apologize, there's one Italian group that have tried to reproduce this work without having an index case to act as a positive control. And the IP assay is not strictly quantifiable and is a bit of a pick to work with. So I wouldn't recommend it as a screening tool for looking for OPG antibodies. And we've spent a couple of years trying to get an assay that is reproducible and is remotely robust. And the theory is very simple, and we have now got an ELISA, enzyme-linked immunosorbent assay, where we put OPG on the bottom of a plate, add the serum to it. If you recognize it, you've got some antibodies still stuck down after you've washed it several times, and then you add a labeled antibody and you see if you've got signal, and the stronger your signal, the more antibodies you've got. So we've spent a few years trying to get this working, and to anyone that fancies going into developing ELISA, I wish you luck. And this is how it performs in healthy volunteers. We get this clustering of patients with, this is OPG antibody is along the x-axis here, bone mineral density runs up here. So these were healthy volunteers, colleagues from the lab mostly. And they have a reasonable tight clustering at low levels, and our index case is somewhere up here. So we've got a decent dynamic range to work with. And we've now taken this ELISA and applied it to different populations. I had access to a large bunch of serum samples from the islanders of Orkney. There was a study by coincidence that a colleague in the public health department had done looking at bone density and cardiovascular disease in Orkney, and we happened to have a couple of thousand samples where of about 2,000, it's about 1 in 6 of the entire population of Orkney actually took part in the study, and they've got bone density scans in all of them. So I was able to look in a healthy or a population isolate with our ELISA, and you end up with a bit of a spatter pot. If you'd ask my child to sit with an ink spatter and just do it, you'd get a similar effect. You get a lot of low levels of antibodies, and some which now we defined, so you can get a spectrum of results. At some point you have to then either define your antibody by the absolute titer, or you make a cutoff of what is positive or what's negative. And we took a cutoff of the mean of a healthy population plus 3 standard deviations, and that was represented by this line here. So these begin to be positive. Our index case is probably over there on the wall. So these are still all relatively low levels of antibody. And in this general population, we couldn't get any association between those low levels of antibody and bone mineral density. So lesson 1, don't go testing random populations for autoantibodies. It's probably a useful lesson for GPs, whether you're talking about rheumatoid factor or CCP antibody, or dare I say a transglutaminase antibody. You're better off looking to diseases where there's a little bit more of an indication you're going to find something going on. So we did. We looked at the most obvious population, which was our own osteoporosis cohort. So we looked at patients attending a tertiary referral centre with osteoporosis. And there we got a very different pattern. And so again, we see a heavy, population of patients with low levels of antibody, and there's a whole host of different reasons why people will get osteoporosis, and some of these have very severe disease. But what was exciting to observe was this significant tail of patients with higher levels of OPG antibody who, by and large, all had the most severe osteoporosis, so averaging about T-scores of -4. And for comparison, again, this is our index case who remains an outlier. And in this population, you could then certainly show a strong correlation between bone density and both titer and presence or absence of OPG antibody. And this correlation is strong even if you correct for age and sex, and you correct for BMI, smoking, alcohol, all the conventional risk factors that you could throw in. So, as I say, we took this data and we asked Coeliac UK to help us build a cohort of celiac patients to see just how this test will work in patients with celiac disease. And so the data came off the plate reader about 2 weeks ago. I think I analysed it on Sunday night, emailed it down on Monday morning. This is what, I beg your pardon. We will have to wait one more slide to see what it looks like in celiac patients. This is the characteristics in osteoporosis patients with or without antibody. They appear to be a little bit more likely to be men. There was no difference in conventional risk factors, including autoimmune disease, interestingly. And they had lower spine T-score significantly, hip T-score just a trend, and possibly increased rates of fracture. So it's interesting observation. Okay, I think I will now come to the celiac patients. We can. Okay, now, small numbers, and we don't get just as clean an association. These are the ones that are positive. This is a Z score, so adjusting for age. If we could ignore that patient, we would get a similar looking patient, but we can't. So a similar looking picture to the one that we did have in the severe osteoporosis cohorts. We see about 5 out of 105, so it's just under 5% of patients by this definition of having a score greater than 3 standard deviations above the mean of healthy controls are positive. And there is, within that, a significant correlation with lowered bone mineral density Z scores. That association is true even after you've corrected for age and sex. It's not going to be a perfect test, and this patient clearly has pretty high levels of antibody but has resolutely normal BMD. So there's a lot of further work to do, but I am positively encouraged from this preliminary data that we're onto something that is of interest. Clearly, we are going to go on and look at a whole cohort, I hope ultimately of 600 patients, and I'll come back to you in a couple of years' time when we've gathered all of those patients and we can see what it looks like with bigger numbers to support it. This is the data that I have today. And you can do a similar thing, and you can look at what are the clinical characteristics of these patients. They're certainly not a confounding by age. If anything, the antibody positive were a little bit younger than the negative. They were a little bit slighter in weight, so that is a confounder. In terms of spine T-score, there's a trend to lower T-score, but it's non-significant. The Z-score, when we strip out this effective age, is significantly lower in the antibody-positive cohort. Just 5 patients emphasize T-score, lower, trend to lower but not significant, Z-score lower at a cutoff of 0.05 p-value. So those are our data. So by conclusion, before lunch, OPG antibodies represent a novel mechanism of osteoporosis. The wider clinical significance is yet to be established. We still just have one case report in the world literature. Our very preliminary results from 100 patients have identified less than 5% of celiac patients with higher levels of the antibody who do have lower BMD. We'll need to do a bit more work to see if those antibodies are functional. We'll obviously need to extend the cohort, which is ongoing. We're at about 300. We're a year into a 3-year project, and we've got 300 patients so far, so I'm optimistic that we will get there. And I hope as well this cohort will allow us to look at all conventional risk factors for osteoporosis and hopefully just give a bit more information about who it's appropriate to treat. We've also got access to serial bone density scan results, so I'll be able to give a bit more data just on a natural history of bone density in patients with celiac. So I think there's a lot of work which, together with my gastroenterology colleagues in Edinburgh, we'll be able to do. So I look forward to doing all of that. Specifically then, I should commend my gastroenterology colleagues, Jackson Sangi, Alan Shand, Peter and Helen Gillett, Clive Goddard, and within the lab, Nick Kennedy, who've given support for all of this within the department and within the public health department, being funded by a number of agencies, but of course specifically thanks to Coeliac UK for their support. And thank you for your attention.
Thank you very much. That's an excellent talk. Any questions from the floor? May I ask you a question before? A really naughty one.
Go on.
Did you have a passport today, and will you need one next year?
I sincerely hope not.
Mario.
I assume that the samples you used for the celiac patients were baseline.
No, I mean, this is a real-life cohort collected opportunistically wherever we can get hold of them. So some of them are new patients, and I go to the dietitian clinics and recruit patients at baseline. The majority of these patients have established disease.
The reason I'm saying this is, of course, what we know a bit about celiac disease is that if you go on a gluten-free diet, there's a possibility that these antibodies might disappear. There are people showing that autoimmunity might be reduced and so forth. So it would make sense that you collect some newly diagnosed ones as well and compare and see whether they...
Undoubtedly, the newly diagnosed patients are the most valuable, and I am trying to flag up so that when they come back to the return clinic, we can get repeat serum as well. I mean, there's lots of things we're looking at. We will gather DNA. It'll be nice to gather RNA and look at before and after gluten-free diet. There's so much research you can do, and we're going to try and do as much as we can, but good point.
Thank you very much. Fascinating. It's only 5 patients, and they haven't got any other autoimmune diseases, I gather. But have you done an autoimmune antibody profile on them? And have you correlated the height of the transglutaminase antibody titer, for example?
So we haven't done an autoantibody profile on these patients. We've got stored serum. You could do that. You then have the issue of what on earth you do with the result, but that's fair enough, you could do it. In terms of the analysis, yes, we've analysed both by absolute titer of antibody and by presence or absence, so categorical or continuous variable. And the association is still there, whichever way you do the analysis. I think for general terms, I'll just use the categorical.
I was wondering whether you actually thought about the more direct role of the anti-TG2 antibodies on the bone mass itself. I mean, just to give you sort of a clue, I mean, we have worked on the TG2 knockouts, and we know that the TG2 knockouts are osteoporotic. And if you do a double knockout with another transglutaminase, in fact, they get even more osteoporotic. So we know that the transglutaminase played directly a really important role in regulating the bone cells. And so the question is, isn't it not just the TG2 antibodies themselves which affect, bone mass?
I mean, clearly there's a close correlation. There will be a multitude of different reasons why patients with celiac disease develop osteoporosis. I suppose in our index case, his celiac disease was treated appropriately, followed a diet, his autoantibody, his TTG levels dropped to normal. He still had very active bone turnover, so the ongoing disease that was seen couldn't be attributed to any direct effect of TTG antibodies. But yes, we know that's clearly another factor that needs to be added into a mix when you're trying to work out a rational approach to managing osteoporosis and celiac disease, which is needed.
Okay, any further questions? Dr. Ritchie, thank you very much. It's really fascinating work.